Welcome to the ASRS Oral History of Retina series. The purpose of these interviews is to capture first-hand stories from individuals with unique retinal insights of historical significance.
Through these discussions, we will fill in gaps in our understanding of the evolution of the science and practice of retina. And it's our hope that these discussions will serve as the illuminating element in the larger mosaic of the history of retina.
It is my honor and privilege to be joined by a true leader and legend in retina, Dr. Julia Haller, ophthalmologist-in-chief at the Wills Eye Hospital. Dr. Haller is an internationally recognized retina surgeon and scientist who has innovated significant translational advances against blindness. As we'll hear today, she is also an extraordinary leader in academics and organized medicine, blazing a trail for generations of women in retina. In 2007, she was appointed ophthalmologist-in-chief and William Tasman, MD, endowed chairman at the Wills Eye Hospital and professor and chair of ophthalmology at Sidney Kimmel Medical College at the Thomas Jefferson University. Dr. Haller has published over 400 scientific articles and book chapters and serves on numerous boards. She is the past president of the American Society of Retina Specialists, the Retina Society, and the Board of Trustees of the Association of University Professors of Ophthalmology, as well as a founding member of Women in Retina. Her list of national and international honors is extensive. We are truly honored to have Dr. Haller join us for Leaders and Legends for the American Society of Retina Specialists. Welcome, Julia.
It's a pleasure to be here with you, Tim.
You have a unique story to tell with us today, and it starts literally when you were born.
I was born to two physicians who were at Johns Hopkins. So I had later, fast forward, I spent 27 years of my life at Hopkins, and I started there as well.
So Julia, born at Hopkins, ultimately coming back to Hopkins, take me through that journey along the way.
Well, I went away to college and medical school and decided to go into ophthalmology. I actually wasn't sure what I wanted to do, and my dad suggested that I come down in the summer before my fourth year in medical school and do a rotation at Hopkins. So I spent that July and August at Hopkins and decided to go into ophthalmology. It was late. Pretty much everybody else had already slotted into that pathway. I knew I wanted to go into surgery, but I hadn't decided which area of surgery. And I had actually already applied for a residency in surgery, so I knew I was going to do an internship at least in surgery. In those days, we didn't have the match. We did have a match, but it was a rudimentary form of the current match. And side deals were made, and what would now be totally illegal types of discussions were held. So Neil Miller, who was in charge of the lineup at Hopkins, said that if I would agree to come, they would not match me the following year, and I had a bye year, and then I could be in the next class. So I took the deal.
But I think you did something pretty remarkable with that year also, right?
Yes. It turned out to be fabulously remarkable and very influential in terms of my thinking and also how my career played out. I went and talked to Dr. Patz. Arnold Patz was the chair at Wilmer at the time, and I remember, he was always so charming and warm, and he suggested that I go work with Fred Jacobiak, who at the time was at Manhattan Eye and Ear. So I spent the year with Fred, and it was great. We ended up writing 7 or 8 papers. I got to meet lots of people. He started a pathology course for all the residents in New York at the time. That's when I realized there were something like 250 residents in New York and about 35 programs in the greater New York area. And it turned out, I met Jerry Shields that way. People from all over the country came in to speak, and I was helping organize those sessions.
Take me back a little bit to being a resident and then a chief resident at Wilmer, because there's a bit of firsts along the way for you for that.
It was early days especially for women at Hopkins, and I remember talking to my co-resident Patty Smith in the emergency room at night, and Ron Michaels had come down to get a pair of forceps because he had to take a suture out of a patient's eye or something like that. And there were 2 women in the ER, and he came down and he went, well, the whole residency is being taken over by women. This is just the way it's going, I guess. Well, you go, girls. I mean, it wasn't negative, but there were 2 women out of 5 in our year. There was 1 other woman, so there were 3 out of 15 residents, and there had never been a female chief resident. So it wasn't exactly that the whole residency was going female. But things were changing, and then Dr. Patz asked me to be chief resident, and I was the first female chief resident. In those days, there was much more residency control over a lot that we did. There weren't the requirements for supervision that we have now. So we really did run the residency.
And the chief resident essentially was an early faculty position, the way I look at it. So, and before you got there, you did your fellowship training.
Right. I was the first American fellow that Ron had. Suzanne Binder had come over from Vienna for a while with him too. But yes, and in those days, you pretty much got accepted into the fellowship. There was no match for the fellowship. And if you had been picked as chief resident, then they were pretty much willing to have you be their fellow. And Ron was, he was very controlling. And one of the downsides of the fellowship was that you mostly watched him and learned from him and worked like a dog from 5:30 in the morning till 10 at night, including Saturday and Sunday. But you had the advantage of seeing so much pathology and so many surgical cases. And then, when you got to be chief resident, that was your chance to practice what you had learned.
So you're there, you've done the fellowship, you're the chief resident. What happens next?
Well, then I joined the faculty, but it was not an obvious step. Ron was very territorial. He had taken on Bert Glazer, and he was excellent. I mean, he had an unending appetite for more patients and could handle, if he had to put 3 extra cases on, that he would come in at 4:30, start early, get the nurses in, and still make his plane to Alaska to lecture or whatever. And Bert Glazer had come on board, Serge DeBoustros had come on board, and Dr. Patz pretty much did an end run, in retrospect, around Ron. And the managed care situation was just evolving, and there were some new HMOs that were forming, and they were going to offer capitated care, which was problematic. So Dr. Patz suggested that I handle those, retina cases that weren't really worth it. Right. And that got me onto the faculty. And also Stuart Fine was welcoming. So I did some medical retina as well. And that was my toehold. Correct. And then I went from there. So
you are really one of the first people kind of bridging that medical surgical divide at Hopkins at the time, correct?
Yes, that's absolutely true. And it took a few more years before it was bridged enough to have a combined fellowship, but little by little, we did get there.
What were those early days like for you at Wilmer?
Well, they were great days. They were exponential learning curve days. They were, I think, for all of us, we're getting started in our career, we're trying to find our niche. We're ambitious, we want to do everything. It was a great teaching environment. Jean Dewan had gone down to Duke and called me up and said he had this young resident named Mark Hamayan that he thought would do really well with a little polish from Hopkins. I'm not sure exactly how Jean put it. So that's how I got to know Mark. He came up, I think he wrote his first paper in ophthalmology, or one of the first ones. He's so prolific, but with me. And years later, when Mark had gotten Second Sight up and running, and they were going into their phase 2 and 3 testing, he asked me if I would be one of the surgeons, and I ended up being the #1 enrolling surgeon in the phase 3 trial of the Argus 2 implant.
So Julia, you've had the opportunity to work with some remarkable peers and colleagues, and one of those, I think, was Dr. Al McGuire. Could you tell me a little bit about how you met, and then how that comes around in your future career?
Al, of course, was a few years behind me in the residency, and when we first got acquainted, it was startling because he had almost stalked me throughout his career path. He had gone to Princeton. He had been in the same eating club. He had the same major. He had the same thesis advisor. Then he went to Harvard Medical School. He had the same advisor at Harvard Medical School. And then, of course, he had come to Wilmer. And, of course, we got to be friends. And he and Jean, even in those days, were working together. And the rest is history from that standpoint, too, of course, because they went on to develop gene therapy, Luxturna, Spark Therapeutics came into being. They went through the phase 1, 2, 3 trials. And so he asked me if I would consider being the third surgeon on the Luxturna trials, the FDA phase 2, really it was phase 3 by then. So I had the incredible honor of participating in the first gene therapy ever to be approved in humans. And it was because of the old connection going way back to Hopkins in the late 1980s, early 1990s.
So you've been in the right place at the right time, but I don't think either you or I believe that's enough. So could you give me a little insight as to how you look at that?
Well, I think you do have to have the basic ante. You have to be at the table. Some things that have come up, for example, in the early days of anti-VEGF therapy, Wilmer was an odd place because there was a real division between medical retina and surgical retina. So when some of the early anti-VEGFs started to get into phase 1 studies, none of the medical retina people wanted to have anything to do with it because they did no surgery, no procedures. They didn't want to be putting anything in the eye. So relatively junior me got to be one of the first, Dan Martin and I were the first to inject anti-VEGFs in human eyes back in the early 1990s. So, that was another situation where I was poised. I was a surgical person, and I could pick up the scrap from underneath the table and run with it.
And, I think people look at your career, as a remarkable career overall, and it is, but also incredibly remarkable as a woman in retina. And I know that you get asked about mentoring often. So how do you look back on that journey, and do you have any sort of unique insight to where women are now and what we can do to do that better?
Well, I think it's better in some ways and worse in some ways for women. It was an advantage for me to feel pioneering because that, at a low moment, I could at least tap into that to keep me going.
I don't think when people look at you, they ever imagine you having a low moment.
Well, I think we all have low moments. and particularly surgeons and physicians. And I know I've had some very low moments in the pandemic, particularly with people who've delayed care. I mean, I have 3 young diabetics, literally late 20s, early 30s, who are blind, NLP blind, who should not be. By the time we got to them, try as we could, we couldn't save anything. So I think for that reason we have. On the discouraging to me side, I have tried to laugh, and it's easier to laugh now. When I was a first-year resident, my first sclerobuckle ever was a part-time guy who was operating and came in, and I really had no idea what I was doing exactly, but you sort of hold the sutures and things. And he started out and put his indirect on his head and took the 20 diopter lens and was focusing it. And he turned to our nurse, the scrub nurse, and held the 20 diopter lens right up to her breast. She was scrubbed, and he's adjusting his indirect, and he's got the 20 right there, and he goes, "This is the perfect target. It's round and full and fills the field." And I was just sitting there going, what? But this is a long time ago. I mean, people did not get kicked out of the hospital for things like this back then. I was pretty incredulous. And she put up with it. Everybody went, "Ugh, that's just the way he is." And but then as the case went on, we finished, and at the end he said, "Well, why don't you give Julia the indirect?" Everybody always says Julia instead of Dr. Haller. They'll be with my husband, I'll be places, and they'll go, "Well, Dr. Gotch and Julia, why don't you come on in?" But maybe it's nice. Anyway, they gave me the indirect, and I put it on. I took my 20 diopter lens. I put it right on his crotch, and I said, "This is a terrible fixation target. It's small. It doesn't fill the field." I couldn't have picked a worse target. And to his credit, he laughed. But that kind of stuff would happen, and I would try to just make it into a funny story to tell people about. I really didn't see myself as a female crusader. I just wanted to be one of the boys more and do the things that they did. So one of the boys, I just have to tell you this quick story. When I got into the Vitreous Society, and this is literally, I looked it up, it's 30 years ago this year, hard to believe. But I was in Chicago, where we are today, at I think a mid-year forum meeting, and I happened to be in the gym on an exercise bike right next to Andy Packer, who was one of the founders of the Vitreous Society. And Andy told me about it and got me to put in my application. And sure enough, a few months later, in the mail, a certificate arrived in my office, and it said, "To Dr. Julia Haller, in recognition of his contributions to the field of vitreoretinal surgery." I mean, are you kidding me? And it was signed by everybody on the board. Well, so I wrote a letter to everybody whose signature was on my certificate, and I said, now that I am safely a member of your august society, I feel that I must come out of the closet and tell you that I am in fact female. So, as you might expect, with the characters whose names were on the certificate, I got a variety of responses, some of them claiming they had not had an opportunity to review the draft and that it was not their fault and they would soon be giving me a corrected certificate. But my funniest one was from Jerry Bavino, who, not surprisingly, Xeroxed it and put an N after my first name, so it read Julian A. Haller.
So many problems, right there. But you played a remarkable role in the Vitreous Society, along with some really luminary members of our society, moving us forward. Can you tell me a little bit about that journey?
When the meeting first started, it tended to be in the Caribbean. There were a few friends. You had drinks. You talked about interesting cases. That morphed into more reporting research studies. And I remember when we first started having courses, and there was pushback because some people felt, so at every step of the way, there's been pushback, which, no surprise, knowing life and knowing people. But the founders, of course, loved what they had created, and they didn't want to lose any of the je ne sais quoi of the Vitreous Society. And so that was the difficult transition. The problem with the name Vitreous Society was, of course, first of all, people didn't know what it was. And also, it was partly that knowing the founders, that they were often tongue-in-cheek anyway. I mean, look at the story of Jerry Bovino and my certificate. So it was partly funny that they named it the Vitreous Society, but then it became a more serious organization, and also it was the only truly representative organization for retina specialists. So I remember when we did do the meeting with the conversion to the American Society of Retina Specialists, Kirk had done all his homework. So he knew American or national or, society or college, or had every possible synonym. And we worked them all sorts of different ways, and we were worried about acronyms that didn't work. Gene was brainstorming on it too. Other people were as well, but I was sitting right next to Kirk, and he had so much stuff on his agenda, and he was just like, energy was burning, and he was radiating. It was tense, because some people were totally against it and felt like it abrogated every fiber of effort that they had ever put into this organization that they started. I think, now looking back, everybody knows it was the right thing to do.
Julia, you've had so many sort of pivotal moments in Retina, and we've had an opportunity to touch on several of them, but you've played a role in the anti-VEGF story from the very beginning in a way. And I think that's one of the remarkable beginnings in our field that has revolutionized eye care for our patients. Can you tell me a little bit about how that happened?
We had, in 2005, our annual meeting in Montreal, and the Marina study results were the hot featured item on the program. So the biggest morning symposium, was going to be new treatments for macular degeneration. And we had a problem because the room was packed. There was not a seat empty, and that's because, and this is the first time I had seen this in ophthalmology, there were so many analysts from the street, reporters, as well as, of course, every single person who was there at the meeting to hear what the results were. And indeed, they were blockbuster results. It was so exciting. And Genentech had teed the whole thing up by being a platinum sponsor. They had a big party that night. A lot of their leadership was there at the meeting in Montreal. So that talk rolls out. Everybody's jaw, is dropped. And then we had a paper from Wilmer, Quan Wen, using Avastin IV, because that had become available. IV Avastin had worked to cause regression. And then up stands Phil Rosenfeld, and he's aliquoted the Avastin out of the bottle and injected it in some humans, and everybody's going, what? And you could see the blood draining from the faces of all the Genentech sales reps and things like that. Genentech was really used to oncologists, and the oncologists were totally in lockstep with them. They used exactly the dose and exactly exactly according to FDA approval, and wouldn't even think about using anything different. And so they were just astonished at the culture of retina specialists. And they decided that they weren't going to sell Avastin to compounding pharmacies and get it in the hands of crazy people like us. And so the retina community just rose up in fury. And it was so bad that there was a big push, and by this time I'm president, there was a push to get the Genentech people up on stage and publicly humiliate them by ripping up their support check and hurling it into the audience. And I went, no, we're not going to do this. Pat Wilkinson was president of the Academy. Now, this was also propitious because Pat, of course, is a good friend. And we went way back and wise. And so he and I both went to Washington, and we met at the Academy office there with Art Levinson, who was the CEO of Genentech. I mean, this was a busy guy making multi-million dollars, so this was an issue. And Art flew all the way out from San Francisco, and we just put all the cards on the table and talked about, this is a terrible, terrible situation. How can we make it better? And came up with some ideas. And one of them was that Sue Desmond-Hellmann would speak at the Academy in a forum, and that she would speak with our representatives. And it turned out that it kind of evolved into a conversation with Kirk Packo and Sue. I was moderating, and tempers were so high, and emotions were, it was like we were on a dynamite box that was about to explode. We actually had guards posted at all the entrances, and every microphone so people could come up and ask a question, every microphone was wired so that I could turn it off if somebody, went into a rant. And it was a famous debate. It was the one where Kirk, alluding to Ronald Reagan, showed slides of all the things Genentech had done to alienate the retina community and built it into a wall like the Berlin Wall. And instead of saying, Mr. Gorbachev, tear down that wall, he said, Dr. Desmond Hellmann, tear down that wall. So poor Sue got up. I mean, how can you compete?
It's not possible.
With the impresario. So Sue got up and did her best. And actually, she was pretty darn courageous to face that ravenous mob of people. At least it was an initial step. The next year, Genentech rolled out this plan where we employed the monitor group. And they came in and worked with the board of the ASRS, and I was still president then, looking at trying to educate retina specialists about retina practice and the economics of retina practice. That was a very good sort of healing project that rolled out over the next 18 months or so.
So, Dr. Haller, you had one of the most unique careers at one of the top eye institutions in the country, my alma mater, Johns Hopkins, the Wilmer Eye Institute, and then you make an incredible transition to the Wills Eye Hospital as the ophthalmologist in chief. How does that come up? How do you think about it? What drives you to do that? And then we'll talk a little bit about what it's like for you.
Well, it was, again, it was one of those times when it was possible. So I think there were times that it would not have been possible. I had just gotten out of the operating room when the executive recruiter called me, and I kind of blew her off a little bit because I was like, look, I'm really busy. And I was worried about a couple of cases, and I thought, how could I possibly make this move? But I thought about it a little bit more, talked to some friends, and several people said, this job might make a lot of sense for you. When I first took the job, everyone said, oh, this is going to be such a change. This is going to be a totally different model. Wills has always had these groups of private practices. Hopkins is the ultimate academic place. Yet, when I got to Wills, it was people who had gone to the same schools I had, trained at the same places, cared about patients the same way I did, had the same ambitions and drive, and many of them were friends. I mean, I actually didn't have any super close friends, which was part of the scary piece of it, but that's been one of the fun things too.
And that is, you have a remarkable faculty at Wilmer, and then you have an incredibly remarkable faculty at Wills.
Exactly.
So I think that you fit there, but the model was so different. But I think you've been able to make changes too along the way that have really benefited the clinicians and the institution. Can you tell us a little bit about how you see that and where's the vision for that?
When I first got there, I would say one of the big changes that happened almost immediately was that the three somewhat, I don't want to say warring, separate retina groups. Very independent retina groups who sometimes didn't agree with each other, but who all came together for teaching, and we're all on the retina service at Wills. They amalgamated. So that was nice because we had a group that was really doing research together and pulling together for fellowships and other things. And so it rose up organically, and I think that if that was going to happen at Wills, it had to happen that way. So we have an academic track now, and these are fully employed faculty, and it's supported by philanthropy and everything, and their hard work and grants, and we've also built up more of a research infrastructure to support their time and effort.
And I think you and I would also agree that ophthalmology is great, but retina specialty, especially surgical retina.
I mean, we've been at the tip of the spear. I mean, I feel sorry for other specialties. I mean, from laser to gene therapy to retinal chip implants. I mean, it's been retina leading all of medicine, much less ophthalmology. So, yes, we have been so fortunate, and it's only going to get better. And I think it's an incredible time to be in the specialty, and we all got to work as hard as we can to make sure that we stay independent, and that we stay strong, and that we're allowed to take care of our patients the way they need to be taken care of.
Couldn't have said it better. So Dr. Haller, thank you so much for joining us in Leaders and Legends for the ASRS.
Thank you, Tim.